Hello everybody and welcome to today's webinar, Intraoperative Quality Assessment of Tissue Perfusion using ICG. Before we get started, I would like to go over a few items so you know how to participate in today's event. You may have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select phone call in the audio pane and the dial-in information will be displayed for you. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of your attendee control panel. We welcome you to send your questions in at any time during the presentation, and we'll collect them and address as many as we're able during the Q&A session at the end of today's presentation. It's my great pleasure to introduce Dr. Anna Dupre. Dr. Dupre has been a medical physician, lecturer, and scientist at the University Medical Center Hamburg-Eppendorf since 2009. During this time, she has mainly concerned with the quantification of ICG fluorescence in animal models. She has already published a number of publications in this regard. Nowadays, she works as a consultant in visceral and thoracic surgery in the same department. In addition to this field of activity, she is primarily concerned with bariatric and minimally invasive surgery of the upper GI. The current focus research is the transfer of research results into the clinical field of activity, in particular into esophageal surgery. Dr. Dupre, over to you.
Hi everybody, thank you for joining this day webinar, and thank you, Jill, for this nice introduction. I'm also really grateful for this opportunity and the invitation. And as you heard, my name is Anna Dupre and I'm going to start with my webinar. So what I'm going to show today is a little overview over our experimental studies concerning the issue of quantification using the ICG fluorescence angiography. We try to find a method which can accurately predict the perfusion of different clinical settings and in different visceral tissues. And after that, I want just to give you a small impression what we did in clinical applications and a few examples and a future outlook. And I'm really keen on your opinions, and I'm open for criticism. And on the last slide, you can also find my contact information. So if you're interested in a future a collaboration or a future communication, so feel free to contact me after this webinar also. So our first study was a porcine model of a gastric tube perfusion. Our aim in this study was to evaluate and validate the perfusion using ICG. And we correlated the ICG fluorescence angiography in this model with the technique of fluorescent microspheres. And this technique is kind of laborious, and the quantitative assessment of the gastric tube perfusion with the microspheres is in milliliter per minute per gram of tissue. And I don't know if you are used to this technique, but you have these little microspheres and they stick in the capillary bed of the tissue, and then you can just do a quantification of perfusion afterwards. So we tried to correlate the ICG fluorescence with the other technique with the microspheres. Why did we choose the gastric tube model? We have chosen this model because it is a pure one vessel system, and if you're used to the visceral surgery, it means that you do not have any false high results due to collateral perfusion. And from a surgical point of view, or the better assessment of the perfusion of the gastric tube is mandatory to avoid future complications or surgical major complications, because, as you know, the future anastomosis in esophagectomy with gastric pull-up is performed in the tissue with the worst perfusion of the whole gastric tube. So in the pig model, we have formed a gastric tube analogous to the technique used for esophagectomy, and the entire perfusion depends on the gastroepiploic artery, and the best perfusion, of course, is expected proximal to the gastroepiploic artery, and the worst at the distal part of the gastric tube, and where the future anastomosis is going to be. So we did in a first study just 7 animals, just 7 pigs, and we carried out the measurements at various blood pressure points in order to detect even minimal fluctuations in the perfusion and to figure out if ICG is or it is feasible to detect these minimal changes using ICG. So our blood pressure goals were achieved by titration of norepinephrine up and near, and then we just waited like 30 minutes of equilibration between the measurements to then perform our measurements. So this is what we then did. We defined regions of interest in these studies, and this were evaluated using the ICG fluorescence and the microsphere technique. And as I told you before, we just choose these regions of interest, the proximal region near to the gastroepiploic artery origin, in the middle of the gastric tube, and in the distal part of the gastric tube. And on the right side, you can see on this pictures the porcine gastric tube. It's a little bit thicker than in human patients because the gastric wall of the pig is really thick, and it's not possible to make a smaller gastric tube, but we tried it as small as possible. And on the picture at the top, you can see a fluorescent image. We used a homemade or custom-made fluorescence camera, which was built by the Institute of Laser Technology in Ulm in Germany, and it was especially for our experimental setting. So what we then did is the Institute of Laser Technology also developed a software to turn the ROIs into a fluorescence intensity curve. And if you are using the SPY system from Novadac, this system is also able to turn the fluorescence intensity into a curve, and then you are able to evaluate the intensity using this curve. And we tried to, or we calculated different parameters using these curves, which were generated by our software, and it was the slope of fluorescence intensity, which is the maximal slope, this kind or this part of the curve, the maximal slope during the increase of the time-dependent fluorescence curve induced by the first wave of the dye passing the capillaries and the arteries. And the second parameter was a background subtracted fluorescence intensity, and this parameter is calculated using the initial intensity of the fluorescent curve subtracted from the peak flow intensity at the end of the curve during the first passage of the dye. What we did in the gastric tube model is also that we measured a time to slope. So we defined a time between the injection of the ICG dye to its first slope. So I'm going to show you a few curves later on, and I'm going to explain it again because it is probably a little bit confusing when you're not used to it. Each sequence was recorded, and then we evaluated and validated this data. So this is an example of a fluorescence intensity curve, and as you can see here, we have the blue curve is the proximal intensity curve in this region of interest, and suspected. We have the best curve in this part of the gastric tube because it's the nearest part to the gastroepiploic artery. And you can see the time to slope after injection is really short. Then you have a really steep increase of the fluorescence intensity, and then you have the outflow of the ICG dye from the tissue. In the middle and in the end of the gastric tube, you can see that first the time to slope is really slow. It's getting slower and slower, and this is what we are going to suspect in this study. And then you have also that the slope is flatter and flatter, the more way the blood has to pass. So these are the data, and I'm really, or the data we are going to publish, and I'm really happy that it's accepted at +1 and is going to be published in the next weeks, I hope. And this quantification technique showed this prolonged way from the arterial radix to the distal part of the arcade under hemodynamic changes. And during vasoconstriction and during volume overload or during other patient individual factors, the perfusion might be reduced or changed. Nevertheless, and this is the important thing, the BSFI, this baseline subtracted fluorescence intensity, is not affected by the hemodynamic changes because you are just subtracting a baseline value from a peak value. The TTS and the SFI are parameters which represent only the arterial inflow into the capillary bed, and that's the reason why these parameters are correlated with the hemodynamic itself. So in this study, we conclude that it's possible, and we could predict the hemodynamic change, the perfusion or the suspected perfusion of the gastric tube in this one vessel model using ICG-FA, and we could quantify these findings, and we correlated them to the micropheres, which showed a well correlation, and of course, further studies are necessary, and later on I'm going to give you a little teaser to our next studies. So what did we else? We did a second study, and this was also a porcine model, and we was dealing with the question, what is perfused enough? And the intraoperative decision-making about potentially reversible ischemic areas is still really subjective and highly depends on the experience of the surgeon. Normally, the surgeon evaluates the appearance of the serosa. The mucosal ischemia cannot really be evaluated, and sometimes or often an under or over value of the extent of the tissue destruction is resulting. So normally, here you can see a picture of our experiments using a model of mesenteric ischemia, and as you can see here, we have on the left side the really ischemic part of the bowl. Everybody is, I guess, agrees, and on the right side it's normal bowl, and then we have this area where the ischemic part turns to the normal part, and this is a part in the clinical routine where the surgeon dissects and resects, and you never know if this part is going to be perfused enough, or do we have to do a second look like we usually do it, or do we have to resect it at the first time? Oh, I'm sorry. So in this experimental setting, we randomized the pigs into 3 groups with total ischemia durations of 3, 6, and 10 hours, just to do a true clinical setting, and we had 3 areas. It was a ischemic, a transitional, and a control area, and we had 3 measurements like baseline, a time of occlusion, and a time of reperfusion. Here's again the areas that we defined. This is before we did any kind of ischemia. Then we had the 10 hours of occlusion, 3, 6, or 10 hours of occlusion, and then we had the reperfusion period where we did the measurements. To introduce a safe ischemia of the bowl, we dissected a side branch of the mesenteric artery, and we closed it. And in the porcine model, it's probably important to say that the pig has a lot of collaterals, so you have to dissect the whole mesenterium and also the veins, because if not, you cannot induce a mesenteric ischemia. So this is a little film from our experiments using again this this custom-made camera. I'm sorry, this is in German. So here we have the baseline picture. I hope you can see it well. Later on, the film's a little bit better, I guess. Then we have the occlusion, and on the left side, you will see darkness here. Here's a transitional area on the right side, the control area, 6 hours after reperfusion. It's another pig because it was different pigs. You can see that it's not really good perfuse on the left side. And I'm sorry, I was too slow. After 10 hours of reperfusion, you can see that the left side is still dark, yeah, reflecting this non-reversible ischemia. And on the right side, you have still a normal fluorescence. So what we also did in this experiments is the transient time flow measurement in the IMS side branch to display the flow in the mesenteric artery. And you can see impressively that with increasing time of ischemia, the compensatory hyperperfusion occurs after reperfusion. The green curve is the 10-hour group, and the blue one is the 3-hour group. And this is important to evaluate and to interpretate the ICG fluorescence, because the fluorescence quality is going to be much brighter because you have a hyperperfusion in this area. Just as a little reminder, we also quantified, or we evaluated the background subtracted fluorescence intensity and the slope of fluorescence intensity. We had the ROIs I showed before. We had a ROI in the ischemic part, in the transitional zone, and also in the control zone. And well, in order to compensate for hemodynamic differences and to make it easier to calculate or to interpret the results of our parameters, we calculated a ratio for this experiments, and we are really satisfied with this ratio because it makes it much more easier to interpret the results. We usually calculated a ratio to the baseline values, so you avoid changes in hemodynamics during an operation, during or a long operation. The fluid input is not that important, and you can just have a quick view if your perfusion is as good as it was at the beginning of the operation, or it is worse, or it's better. And using this ratio, a value of 1 is equal to baseline, and a value over 1 indicates a higher fluorescence intensity, and a value under 1 is a lower fluorescence intensity. So this ratio itself is a valuable instrument for comparing, especially after recurrent measurements in one patient. Here you can see in this one, D1 is always the ischemic part of the bowel, that under occlusion you have no fluorescence intensity, and you have a hyperperfusion in the control group, which is normal because the body tries to react on this occlusion. After reperfusion, you can see after 3 hours that the intensity is nearly the same as it was to baseline. It's nearly 1. And you have a higher fluorescence intensity in the 6-hour and in the 10-hour groups. This is going to be important afterwards on the next slide. In the BSFI ratio, you can also see that in the ischemic part, you have no intensity, no fluorescence intensity in this column. But after reperfusion, and this is something what we was thinking about a lot, because we couldn't explain at the moment, at the beginning, we could see a doubling of the fluorescence intensity, and this was a kind of confusing for us. The 10-hour experiments showed a nearly or near to baseline value, which was kind of confusing. So if you just look again on the video I showed you before, we know that the 10-hour pigs had no perfusion because it was dark and it was irreversible ischemic. The hyperperfusion in this area of the 6 hours results or is resulting from a pooling of ICG, because the tissue, or probably the tissue, is already damaged, and you have a capillary leakage. So this hyperperfusion and this ICG pooling may lead to a false interpretation of the ICG. So if you're not used to it, you may think that the tissue is well perfused because it's you have a fluorescence in this part of the tissue, but in reality you have a tissue damage and a capillary leakage and a pooling of the ICG in the tissue. We correlated this, or we showed that our histopathologic samples, and we used a score implemented by Chio et al., which is a normal score for evaluation of bowel tissue after ischemia. And in the 6-hour group, this is this one, I hope you can see that, the normal or the median score was 4.6, and 4.6 are denuded really with dilated capillaries exposed and increased cellularity of lamina propria, which correlates with our interpretation of our BSFI fluorescence ratio. So this is enough in our experiments, and it's kind of really special, but I just wanted to show you this data to give you an impression and to help you evaluating your fluorescence in your daily practice. And I have two examples, one in the gastric tube and the other one is a mesenteric ischemia, and what we are working in the future, and we are now trying to bring our experiments or the results of our experiments to the clinical assessment and to the clinical daily routine. So this is a human gastric tube fluorescence And here is the P, the proximal part, and here you can see the distal part, and you see a bright and a quick inflow of the fluorescent dye. And here you have this transitional zone, and we are always marking this part with a suture or with this pencil. And you can see here is a really large gastric tube, but you can see that this part is not perfused anymore. And what we are working at the moment, or my dear colleague and friend and fellow, that Philip von Kroger, is working on a quantification of the gastric tube perfusion, and we are just using a lot of ROIs to determine a cutoff value, because for us it's interesting, or for you I guess also it's interesting, which value in each patient is a value where you can put a safe perfused anastomosis. And he's working on this, and he is like fluorescence or fluorescing every gastric tube that we are doing, and he tries to figure out which is the right cutoff value. And this is just an example from one patient, that you can see that the SFI curve is like dropping down at the end of the gastric tube, and the same with the BSFI curve. And I'm really keen on our data, because this is the most important thing for us in the clinical setting, to determine a cutoff value where we can just decide it's okay or it's not okay to set an anastomosis in this area. And the second example is the mesenteric ischemia. This is a case from our normal emergency case with the mesenteric ischemia. And you can see that you have an impaired fluorescence also in this part of the bowl. And on this side, you just have bowl which is not perfused anymore. And on this part, and what we are doing in this case is also a quantification using these parts which are not perfused anymore, and using the parts which are perfused, and we are trying to figure out which bowl is perfused enough and which bowl is not perfused enough, to avoid probably several operations due to ischemias or due to leakages, because we didn't resect all the ischemic bowl at the first time. Yeah, thank you for your attention. I hope you understand everything I said, and I'm now ready for your questions.
Thank you very much, Dr. Dupre. And as Dr. Dupre mentioned, we are now going to begin answering the questions that have been submitted so far during the presentation. As a reminder, you can still submit your questions through the questions box on your attendee control panel. So our first question here, did they use the camera at different distances from the tissue, and does that affect the results?
No, we always used the same distance in our experiments, because you have to, if you remember, or I don't know what the most of you are using, but if you have the SPY system, you have the two laser points to determine the right distance to the tissue. If you're too close or not close enough, your results may be misleading. So you should use always the right distance, and this depends on the camera you are using and on the system you are using. It's not always the same for the different systems you can buy at the market at the moment.
Thank you. And do you agree that, because this comment is from the same person that asked the question, do you agree that this would have clinical importance during robotic or laparoscopic surgery, for example, with that distance being the same from the camera?
Yes, but in the robotic, we are also using in the robotic surgery. You don't have this this kind of of marking like you have it in the SPY system. It's for the open surgery, and in the other surgeries you don't have this kind of marking. So it's a little bit difficult because you cannot you are I'm searching for the right word. You in the laparoscopic you don't have enough space. This is a problem, so you have to keep it in mind that it may be misleaded, but normally you can use the laparoscopic items and the SPY item because the cameras are really good in comparison to the open cameras.
Thank you very much. Thank you. Now, next question. Could you elaborate on the dosage of the ICG that you use?
Yes, in the experimental setting, we use a little a small dosage. We used 0.02 per milligram per kilogram, because for the porcine model we tried it out in a pilot study, and you have a really hyperfluorescence if you're using more. In the human patients, we usually use 0.2 milligram per kilogram. But in some patients, if you have a good cardiac output, you also have a hyperfluorescence. So if you have a young patient, I think everybody of you has observed this this problem. You can have a hyperfluorescence even if you had the right dosage. And we are now working on a study to correlate the right dosage to the hemodynamics and to the cardiac output and the patient or the individual patient, because I guess it's still an issue which is not clear.
Thank you, Dr. Dupre. Moving on to our next question. What are the pitfalls of ICG fluorescence in the clinical routine?
So one pitfall is, I guess, or I've observed it, that the impatience of the surgeon. Some people are just injecting the ICG and they are like switching with the camera like this. So you do not have the right moment. So when you're just thinking about our results, you have to see the inflow so you can be sure that you have the right perfusion. If you're switching to a tissue after this inflow phase, you do not know if its fluorescence comes from a damage or it's just a rest of fluorescence. So you just have to stand still to evaluate your fluorescence, and you have to decide which part of the tissue you want to evaluate. And this is, I guess, the most common fault that you can make in the clinical setting.
Thank you very much. Moving on to another question, and I'm going to apologise in advance in case I pronounce this incorrectly. Firstly, it says congratulations on your experimental and clinical work. And the question is, are you aware of any study analysing something like pinpoint ischemic zones, like the ones you get after adhesiolis?
No, I don't know any studies, but I guess you mean, but probably you can just contact me later on. I guess you mean the if you have perfusion deficits after adhesiolysis. And I've never tried it out, but I guess you can just use it after a huge adhesiolysis of ours to evaluate the tissue perfusion of the bowel after adhesiolysis. But I've never done it, and I don't know any study.
Thank you for clarifying. And as Dr. Dupre mentioned, her contact details are on the screen for you. Moving on to our next question, does your custom camera have an auto exposure or an auto gain?
An auto game? I didn't get the question.
Um, has it auto exposure and or auto gain?
No, we had to just fix it in one way. We had a physical colleague with us, and the colleague of the laser technology, and we just had to put it always in the same manner to have the experiments right in this setting.
Thank you. So we're just moving on to our last couple of questions. So if anyone is thinking of typing a question in, please do so now. Our next question is a quantitative evaluation necessary at all? Because the fluorescence can be clearly seen in most cases.
I think I have to think that it's important because I'm working with this topic. Sometimes I guess you are not really sure if it's the fluorescence is enough and it's still objective. So it depends on the experience of the one who's using the fluorescence. So to make it easy for everybody and to make it useful for everybody, I guess it is important, or I think that it's important to have a quantification. But I agree that you can use it without any quantification nowadays, and every time you need it. But you need a little experience to use it. And we are just searching for a method to avoid this need for experience, because an experienced surgeon also has a great experience in evaluating the tissue without fluorescence at all.
Thank you very much. Our next question is, do you think diluting ICG to lower than 0.02 milligrams would still be able to properly evaluate the perfusion?
Yes, I do think that, but it depends on the patient characteristics. So we observed, and I guess you observed it, or the audience observed it too, that it hardly depends on the patient's characteristics if you have an overfluorescence or a hyperfluorescence or not, and you cannot determine the perfect dose at the moment. We always try to do it with the same dosage in the clinical setting, but sometimes it's like a hyperfluorescence, and if you're too late, you cannot see it right anymore. So I think we need further examinations or further experience just to determine how we can choose the right dosage. And also you can dilute it, but you have to see it, and the camera has to see it. For our experiments, it's not that important because we have the possibility to convert it into the intensity curve, and we can calculate also with lower dosage and lower fluorescence intensity.
And we've got a comment here. It's more of a statement rather than a question, but I thought I'd share it with you anyway. It says, I've learned that hemodynamic status definitely influences the result of FA application during intestinal anastomosis. It can tell you about the hemodynamic status of the patient even before the anesthesiologist becomes aware and tells you.
You mean the way around. No, we did not try it out. I guess it's a little bit difficult, but you can see it because it's the same reason why a young patient, a young healthy patient, has a lower ICG doses, because you have this quick inflow. Probably we can tell with our time too slow, because you can just see how fast it is, but we've never tried it out. But it should be possible.
Thank you. And moving to our final question for today, Dr. Dupre, what are the typical mistakes in the quantitative evaluation?
Typical mistakes are that you're not quiet when doing the ICG fluorescence, that you are moving a lot, not evaluated later on because you do not have a right ROI. You have to just put your ROIs, if you have those regions of interest, not on a vessel, because then you have an overfluorescence, and if you're using the SPY system, you can just try it out because you have the software in this system. So avoid to put your regions of interest in a vessel. Don't move that much because you do not have the right phases of the ICG inflow. And you should keep in mind, indeed, what we discussed before, the cardiac output and the volume status and the dosage of norepinephrine during an operation, because this can react, or this can correlate with the ICG fluorescence. So probably you can use a ratio, but we are not at that time that we can put the ratios in the clinical setting. So we're trying to solve it in this year and the next year.
Dr. Dupre, thank you so much for your presentation and answering all of our audience questions today. And thank you to our audience for attending today's webinar. Once you leave the webinar, you will receive a survey on the presentation, and we really appreciate if you could just keep your browser window open and complete that and provide your feedback for us. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of the International Society for Fluorescent Guided Surgery, with grant funding from Diagnostic Green, and of course our presenter, Dr. Dupre, thank you so much for joining us, and please do enjoy the rest of your day. Goodbye.
Goodbye.